Everybody, and welcome to this week's Power Hour. Today we're going to talk about colorectal cancer, and we have a group of speakers with us today, which we're really excited about and can't wait to hear from. So, as always, my name is Christina Nattagdag. I have with me my colleague Danielle Snyder, as well as Franklin Walker, who is, as always, our eminent moderator. And I just want to, we're all from the North Carolina Medical Society, and I just want to give you a brief reminder about the purpose of Power Hour and how we started. So, as you may recall, if you followed us from the beginning, we started as the pandemic hit in April of last year. And we have at this point, a long list of recordings that we hope that you can go back and listen to. But we really started this as a way to keep building community, keep focusing on conversation, and keep focusing on collaboration. So with that, this is going to be another one of those really interesting conversations. And I just want to remind everybody that this is a recorded session, which will be available in about a week or so at the Kanoff Institute for Physician Leadership website, the landing page. And also we ask the audience to actually be on mute. You are welcome to unmute and ask a question when we get to that point, or use the chat function for questions as well. Without any further ado, I'd like to hand it over to Franklin Walker so he can introduce the guests to you. Thank you so much.
Super. Thanks, Tina. Welcome, everybody. I'm excited because we haven't done a Power Hour in a while, and this is a really important topic, and we have some really interesting guests. So I want to go around and let them introduce themselves really quickly. Christy Williams, will you introduce yourself, please?
Absolutely. My name is Christy Williams, and my husband and 3 children and I live in Davidson, North Carolina, just north of Charlotte, and I am a colon cancer survivor.
Super. Welcome. Dr. Larry Wu, can you introduce yourself, please, sir?
Sure. My name is Larry Wu. I'm actually a family physician, and I'm the chair of the North Carolina Colorectal Cancer Roundtable, an advocacy group in North Carolina. And my day job is also at Blue Cross, but my primary role here today is to represent the North Carolina Roundtable.
Super. Thanks, Larry. Molly Black.
Good afternoon. I'm Molly Black. I'm with the American Cancer Society, and I'm joining you from Asheville, North Carolina. And I'm just been so privileged for the last 14 years to be able to work in North Carolina creating cancer health equity. And so it's wonderful to join you all this afternoon.
Super. Thank you and welcome. Renee Ferrari, please.
Hi, yes, good afternoon. My name is Renee Ferrari. I'm a health services researcher at the University of North Carolina, Chapel Hill, and part of the Carolina Cancer Screening Initiative, which is part of Lineberger Comprehensive Cancer Center. And my current work focuses on improving cancer screening efforts and increasing cancer screening rates in community health center populations in North Carolina.
Super. Thanks, Renee. And the final member of our panel is Dr. Justin Miller, who is actually finishing up a colonoscopy right now, which is so appropriate for what we're talking about, and hopefully he'll join us soon. So let's go ahead and get into our discussion. I want to come back to Dr. Wu. Larry, you had mentioned, and we know that you wear several hats, but the one we want to talk about first is the North Carolina Colorectal Cancer Roundtable. And I'd love for you to give us some background on that and take us through what the initiatives are, just to kick us off. Please, sir.
Sure. The mission of the Roundtable is to reduce the burden of suffering from colorectal cancer in North Carolina through prevention and early detection. And our vision is to eliminate colorectal cancer deaths in North Carolina. Our focus is on vulnerable populations. To my knowledge, we're the only advocacy group for the people who are most unscreened, and that would be the folks who are uninsured. We have an active group. We have representation from gastroenterologists. We have representation from cancer survivors, public health folks, including folks from the North Carolina Department of Health and Human Services, and American Cancer Society, rural providers, and folks from academia. If you look at the gap that we have to close if you look at the folks without insurance, the eligible populations have only a screening rate of 20 to 40%. You compare that for the fully insured population where the rates are up to 75%, and you can see there's a huge opportunity there of trying to get some type of screening down to that population.
Super. As a follow-up, Larry, I want to ask you, what are some of the efforts involved with the Colorectal Cancer Roundtable in order to increase screening among the uninsured and the vulnerable populations?
Yeah, so that is a challenge, and as you can imagine, that if you look at what we all go to, for those of us who will have coverage, we all often think about colonoscopy. Well, the supply of colonoscopy is just not there to screen an entire uninsured population. So we've looked at some best practices to maximize the screening rate. And as it turns out, the stool-based testing, such as the fecal immunochemical testing, has just a good demonstrated track record for detecting colon cancer as colonoscopy based on the information that we have right now. And so if you use what I call the FIT testing, it's the acronym, we can reduce the need for colonoscopy by 90% in this vulnerable population. And we've had gastroenterologists and outcome studies that have bolstered this benefit. So our goal right now is to look at North Carolina and look at the local regional areas to see what type of efforts have been set up. As it turns out, the federal quality health centers are a huge ally in this area as they take care of a lot of the uninsured population. And there have been some successful projects where we are able to launch screening programs for the uninsured or the underinsured at these FQHCs that then partner with a local gastroenterologist who, with the partnership of a business developer, or sometimes it's just the gastroenterologist, sometimes they have to set up a care delivery system where hundreds of people get screened by FIT testing with colonoscopy follow-up for people with the positive tests. And as you can imagine, I think all of you can appreciate, and I'm glad there's someone who's from a smaller town here, that all healthcare is local regional, and especially for those who don't have transportation. So how do we deliver those services? So what can be developed in the mountain, we hope we can develop it for Eastern North Carolina. And you're going to hear more from Renee, who will talk a little bit about the grants and some of the challenges that we've had. But recently we had a recent meeting of a panel discussion featuring folks who have successfully set up these care delivery systems for the underinsured. And they represent counties of Forsyth, Lenoir County, as well as Buncombe County, all the way through Chuan County. So we know it can be done. I think it's just a matter of getting like-minded individuals together for this vulnerable population.
Gosh, that's a great thing, Larry. Thank you so much for that. And so Larry provided me a segue. Renee, let's go to you next. And as a member of the roundtable yourself, I'd like for you to talk about your work with the roundtable, and then also some of this research that you're conducting as part of your project at UNC. Please, ma'am.
Yes. So yes, I've been a part of the roundtable for probably the past couple of years, and working together in the effort to, increase colorectal cancer screening across the state to reduce burden. And part of that has been directly related to research that we're doing at UNC. And with this research project that we're working on, we participate in roundtable meetings and updating the roundtable on what's happening and trying to seek input and engagement from others who attend there to work toward this effort. But I can tell you a little bit more about that research. And so as I mentioned, at UNC, we're focused on improving cancer screening for North Carolinians. And in particular, it's much of what Larry's already said. So our focus in this area is on the low income, uninsured, or otherwise, persons who otherwise have limited resources, what we might call vulnerable populations. A few years ago, we received funding from the university's Cancer Research Fund and from the National Cancer Institute to explore ways to increase screening in our state. And so out of that came what we call the SCORE study, which stands for Scaling Colorectal Cancer Screening through outreach, referral, and engagement. And of course, that's long, so we just call it SCORE. SCORE includes partnerships with many stakeholders across the state and has always included the vision of a statewide colorectal cancer screening program that would support screening for the state's population that's most in need of that.
Okay.
I can tell you a little bit more about it too, with like what our motivation was. Okay.
No, we want to hear.
Okay, so part of the motivation for developing SCORE was our awareness of the national colorectal cancer hotspots that some of you may have heard of. So these are 3 distinct regions in the United States that have a higher than expected rate of colorectal cancer deaths. And one of those regions, unfortunately, is in North Carolina. It covers 11 counties in northeastern North Carolina. So, with this hotspot information and then coupled with our existing work on increasing cancer screening, our desire to go where the need is greatest, we thought, how can we improve screening in that hotspot region in a way that makes sense for the region and takes into account community needs and desires? So we reached out to a community health center that's in the heart of that region. As Larry mentioned, the federally qualified health centers really provide a safety net system for uninsured and low-income patients. And that health center is Roanoke Chowan Community Health Center. And we began discussions with them about how can we together make this work to get more people screened.
So one follow-up question on that, Renee. You said this was an 11-county region in Northeast North Carolina, and it's one of the national hotspots. How does one determine a hotspot nationally?
So that's based on a research study by Siegel et al. And so they've, of course, I don't know all the details of that, but they looked at population level data and looked at death rates, and then saw that there were these 3 regions, and one is kind of the Delta region, and I might be wrong with this, but Ohio, Kentucky area, the Appalachian area, and then our region that just showed that it's just much higher rates of death from colon cancer. They don't really explain why, I think that's still being explored, but just identifying the fact that there are these areas where there's an incredible opportunity to work toward reducing that burden. And the way that we're approaching reducing that is through screening, through improving screening.
Yeah. Yeah, that's very interesting work, and thank you so much. Okay, I want to actually come over to Molly really quickly and talk about what you guys are doing from an American Cancer perspective as it relates to North Carolina. And I know you guys are also a member of the Roundtable, and so that's all good. So Molly, could you give us some background on your work in North Carolina, please?
Absolutely. So first is around education. And, many of the things that, Larry and Renee have talked about is getting what we know works into the hands of the clinicians and the practices. So, for instance, we know that that offering a patient a choice in the screening modality increases your screening rate. And that is something that not every clinician knows, that if they offer a patient a choice, that decreases the choice of no screening, because you're offering them, okay, you're eligible for this at a certain age, and then offering them choice. So there's education to our medical providers. We have been studying colorectal cancer in the hotspot paper that Renee talks about was from American Cancer Society research. We also fund research. Actually, some of the research funded at UNC is American Cancer Society funded research. And then over the last several years, we have been really focused on working with our federally qualified health centers. And those health centers serve the largest number of uninsured and underinsured North Carolinians across the state. And we have been working with them in bringing them to, now a virtual table to really get into their rates, who is not being screened, and looking at how they can get these patients screened. And we have seen tremendous success. In fact, North Carolina has been a leader across the entire country with our federally qualified health centers drastically increasing their colorectal cancer screening rates. And so we're really excited to be able to continue this trend of increasing our rates. In fact, in 2020, when everything shut down, our North Carolina FQHCs who are really working with us on colorectal cancer, instead of their rates going down, they actually held their own. The colorectal cancer screening rates, they held their own and even increased. And so we're very proud of the work of the providers across North Carolina.
That's super. Thank you. Thank you. I think we also might have Dr. Miller joining us. Dr. Miller, how you doing?
Doing great. Just finished a colonoscopy.
Wonderful. Couldn't be more proud of that. Excellent timing.
Thank you.
We started out, Justin, by going around the horn and letting folks introduce themselves a little bit. And you didn't get that opportunity. So if you might do that, please, sir.
That's fine. I'm Justin Miller. I'm a newly graduated gastroenterologist from the state of Louisiana, and I moved to Wilmington in the summer of 2020. I started in private practice over here at the Wilmington Gastroenterology Clinic on Oleander in downtown Wilmington. So I'm proud to be in North Carolina now, and I'm looking forward to getting some more information about local issues.
Super. Thank you for being here. So I want to take a break from what we've started with the screening with our first three folks. And I want to give Christy Williams an opportunity to tell us her story. And I must say a word, I had called Christy in the run up to in preparation for this meeting. And it was lovely of her to share both her story, which is very personal and really tough. And so I hope that our listeners will be as impressed as I was by Christy's story. So Christy, please share it with our folks.
Thanks, Franklin. Happy to. So my story is kind of life as normal. Had just celebrated my 40th birthday, had just run a marathon. I've always been active and very much a clean eater, organic eater, to the point that I drive everybody crazy with it. And I had just a well check, and my internist was looking at family history and said, you're healthy as can be, but there's a little bit of a family history with colon cancer. So, and I'll share what that is, because every physician I have talked to has said, I never would have ordered a colonoscopy on you. So it's worth sharing. So my maternal grandmother had colon cancer twice, in her mid 50s and in her mid 60s, and beat it with surgery both times, didn't need chemo, and lived to be in her 90s. And then the other side of my family, my paternal side, my cousin had colon cancer and unfortunately passed away from it while I was actually going through treatment. So I share that because everyone who knows that story from a medical standpoint says that is just not enough of a history that I would have ordered a colonoscopy on you. But so my internist ordered the colonoscopy, and he did ask if I'd ever experienced any bleeding or anything. And I said, no, I really haven't. Maybe once after a marathon. And he said, it's all I needed. I want you to get a colonoscopy. And so it was scheduled, and I canceled it because I did not want to miss my kid's basketball game. And interestingly, I did start having some bleeding right around that time. And so fast forward, I had rescheduled it. So about 6 months now has gone by since he's first ordered it, and probably about 5 months of bleeding. And, I started with saying just how active I am. And I really thought, okay, I've just turned 40. Maybe I need to tone the exercise down a little bit, that since I've got some bleeding going on, maybe it's hemorrhoids. I really just have no idea. So I considered canceling the colonoscopy a second time. I'm embarrassed to say to all of you, but that time because I didn't want to miss my children's swim meet. And my husband said, you've been talking about some bleeding. I really think you should go. And so I did. I scheduled colonoscopy, and immediately after coming out of it was told that I have colon cancer. And, I don't know your thoughts on this, Dr. Miller. I'd love to hear them in a minute, but there was a part of me who thought, I can't believe that this physician is telling me this without even getting pathology on it. There was no question you have colon cancer. And I think in hindsight, I'm grateful that he did share it that way and not, hey, you might, we need to do a little bit more look into this further. But he just had the experience, and he had seen it enough that he knew that there was no question it was colon cancer. So shock of my life. Again, I just turned 40. My kids were 5, 7, and 9. And so we just quickly jumped into action. The very next morning, I was having some scans, and my husband and I pretty much said we would do whatever it took to try to beat this, go anywhere we needed to go. Throughout my journey, I was at MD Anderson, I was at Memorial Sloan Kettering, I was at Duke, and ultimately I had all of my care at Levine Cancer Institute in Charlotte. They blew me away. I was very impressed. So a few weeks after my diagnosis, maybe closer to a couple weeks, I had surgery, robotically and laparoscopically through the abdomen. They went in and removed part of my colon. And at that time, it looked like there was probably some lymph node involvement, but you never really know for sure until you have surgery. And so what's common for this type of surgery is you remove all the lymph nodes and check them all. And so 6 of the about 30 did indeed have cancer. And so waited about 4 to 6 weeks to heal. And then I was going to start chemo. And right before starting chemo, I was scanned again, and we saw that it had metastasized to my liver, which I had already been given because I requested a chart, and I knew the recurrence rates, and I knew the mortality rates, and I knew that if it spread, that would put me in stage 4, and the survival rate was 5%. And it was just a dark time. I'm looking at my children's faces and their future and questioning so much. And so I did everything that I could from a nutrition standpoint. And there's survivor groups. For me, it's a young colorectal survivor group of Charlotte that I met. And the first time we got together, I'm looking at all these people. Some were going through treatment, some were already out of it. And we were at a brewery, and I just remember thinking, okay, this can be my life someday soon. Please let this be my life, after this journey. And so I had 12 rounds of chemo, and they had me on Folfox, which is oxaliplatin and 5-FU. So 5-FU is the pump, and I'm drawing a blank on the full name of it, but 5-FU is kind of how people refer to it. And did some additional genetic screening, I believe, on the tumor so that we could add on an immunotherapy. And I should back up and say I had a full workup of genetic screening, and everything came back completely normal. So I had shared that little family history, but basically what was shared with me is the best answer we can give you for why you have cancer is it was caused environmentally, which was really bizarre, just knowing what a healthy lifestyle I had led. So I had 1 round of Folfox, and then we added on the immunotherapy, which was Vectibix, and had a total of 4 rounds of chemo, and I was scanned again, and we couldn't see anything. I still refer to that as the best day of my life. I kind of manipulated the system slightly and was able to get the radiology report before it was shared with me by my oncologist. And so my husband and I were trying to read through it and understand, really what this meant, which now I'm quite the expert at reading these radiology reports, but it took us about 5 times before we realized, oh my gosh, they didn't see anything. We just tears and hugs. And so then the decision of, do we continue with chemo? Do we not? And, as you all know, there could be microscopic cells that are not being detected on the scan. So I continued with another 8 rounds of chemo, and then had the decision to whether or not to go in and remove a part of my liver, do a liver resection where the cancer had spread to. And young and healthy, my care team and I decided to go for it. So they went in through the same, 5 or so incisions in my abdomen and removed that part of the liver. And the pathology on that came back as showing no evidence of cancer. So no active cancer, I guess is how I should say it. So I'm just continuing to be closely monitored. I finished treatment in February, and then that liver section was in March of 2020, right before the world shut down. So I'm very fortunate with the timing of all that. I can't imagine having to go to chemo and not having my loved ones with me. So yes, being scanned every 3 months, and February will mark my 2-year anniversary from finishing treatment. And it's such a great success story. So I'm always happy to share it. So yeah, I think that's about it.
Well, for our listeners that aren't on the Zoom call, all of our screening and treatment people on the other side are giving thumbs up and, high fives, as they should. This is an awesome story, and thank you. I do have one follow-up I wanted to ask Christy. Was there any side effects from the immunotherapy or any of the treatments that happened during the course of the treatments, number one, and are you experiencing any side effects currently that you could share?
Great question. So no side effects currently. And in fact, I haven't had any side effects since, maybe a couple weeks to a month after I finished treatment. But my nickname was Side Effect Sally. I had every side effect. And it was interesting because prior to my diagnosis, I thought that you would have the same side effects every month or every 2 weeks when you would get treatment. And some of that is true to an extent, but there was often just new ones that would present. So with oxaliplatin, the most common side effect is neuropathy, so tingling with the fingers and toes. And I did experience that. And I'll talk about this, I think, in a little bit, but was very involved with the integrative medicine department with my cancer institute. And my integrative medicine doctor really pushed acupuncture. There's some research that suggests long-term, the neuropathy isn't as permanent if you get acupuncture while you're going through treatment. And so I did that. Once you have neuropathy about 24 hours a day, it's likely permanent for the rest of your life. And I would say I probably had it about 23 hours per day, but that stopped a couple of weeks after my treatment, and I have never had it since, which still amazes me to this day. And then the immunotherapy. So when they start you on immunotherapy, you'll hear, and the way that I explain immunotherapy just to people outside of medicine is it's kind of a newer generation chemo, but they said you might get just a little bit of like an acne-like rash on your cheeks, and that's really the extent of it, and that they want to see that. If you don't get it, they'll stop it and they'll start you on something else. So I looked like a leper. My entire face was covered, my chest, my arms, and it doesn't hurt. It just looks terrible. And so it comes and goes with those treatments. And there's a funny story that I have to share. So again, being, really into clean eating and just leading a clean lifestyle, I didn't want to put anything on my rash that wasn't organic and really good quality. And people kept saying, you should just try like some Aquaphor or something. And I wouldn't, I refused. And finally, I was so it was just so dry that I did indeed put Aquaphor just all over my face. And I went for a bike ride and came home, and my kids got off the bus after school, and I was kind of snuggling with my oldest. I think she was 11 at the time. And she was telling me about her day, and she leans in and she's looking at my face. And I will say the kids were great with the rash. I think it bothered me that they weren't fazed by it, but she's looking at my face and she said, "Mom, you have bugs stuck all over your face." And so it was the Aquaphor and the bike ride. I guess I went through a swarm of gnats and they were all stuck in my face. And still to this day, it makes us all laugh. But so yes, the rash is the most common thing that you'll see with immunotherapy. You can have some almost like a blister around your nail beds, and ultimately sometimes you'll lose the nail and it grows back. But that's probably the second most common side effect with immunotherapy. And then just dryness, dry skin, dry hair, some nosebleeds, but yeah, I think that's about it.
Well, I felt like I wanted you to share all that because it's really, really important and moving for everybody. So thank you so much. Okay, so Justin, I want to come back to you because you probably had a chance now to take a breath from your procedures this morning. And want to talk to you about several things. The first thing is during COVID, how has that, can you give us some examples about how that's affected your practice, the screening? Molly had said that she thought from her perspective, from the American Cancer Society, at least their statistics, things were holding steady during COVID. But at the practice level, I'd like to hear your thoughts on that.
Yeah. So first, Christy, amazing story. Glad you're 2 years free. I've had a few patients since I've been in private practice that have had similar stories where they come in for rectal bleeding. You think it's hemorrhoidal, and then all of a sudden you're hit with a bum, and you have to change your whole life and prepare for the worst ride of your life. But I'm glad you're surviving, and very good. As far as screening patients during COVID, it hit when I was in training. And we actually, ceased all elective screening tests for 3 months. And we were able to add back a few cases with exceptions because they had symptoms or red flag symptoms that would change it to a diagnostic study instead of screening. And so we were doing probably about a third to 20% of what our normal volume was. And that ended up being a huge caseload after that 3 months that we had to try to make up. And so a lot of our schedules got shifted where we were, working extra days, more time during the day. And then they proposed working some weekends even to try to make up some of that backlog. So I think that was the big thing that hit right away. The private practice did not have a huge deficit of cases. We were able to operate because we're an ASC here. And so we have a little bit different regulation. The hospital did enforce some of those same regulations. And so we had to just kind of shuffle patients around. And then one thing I found that we were doing more than we had in the past was offering some of the stool-based tests that typically we would have, the patient would have met criteria and was willing to undergo colonoscopy. We would have directly put them in for a routine screening test, but we were essentially offering more Cologuard and also FIT testing during that time period.
So, Justin, generally speaking, what are the symptoms that someone might want to pay attention to come in and have screening of some level done?
Well, I mean, obviously, we try to screen everybody for some of the most common red flag symptoms. The top one being rectal bleeding, and that can be painless as well. Sometimes with the left-sided colon lesions, you'll have some constipation, obstipation, decreased stool caliber, or change in consistency. And so those are the things that we're screening those patients for earlier. And if you hear those things, it's definitely not something, it's suggestive of a benign process like hemorrhoidal bleeding or fissures or something like that. and you should take that seriously. In some of those younger patients, we also, obviously we're trying to look for colon cancer, but since that's not as prevalent, we want to rule out inflammatory bowel disease, and that does change their risk for colon cancer. So definitely take that serious between the 20 and 30-year-olds. And now, obviously, we have this new 45-year-old age mark where we're screening patients who are average risk. Some other general red flag symptoms are weight loss, any lymphadenopathy, early satiety, change in weight, which would be more than like 10 to 15% in 6 months. Those are the things we're looking for.
So I was going to follow up with a question, but you just about answered it with the 45 age group now, because when I was coming along, I think it was 50, and they've moved it back down to 45 now. So have you started screening 45-year-olds in your practice, Justin?
Very, very good question. So we are adopting that recommendation that's been put forth by the Cancer Society and the task force. And then it's always been a conditional recommendation by our governing bodies in gastroenterology, but now it's definitely recommended. Again, it was probably more directed toward the subset of African Americans with higher risk, but now we're doing that for every 45-year-old, at least suggesting it. The biggest hurdle has been the insurance company and payer agreement to actually adopt that same recommendation. And so we have had success in a few insurance companies like Aetna and then United Healthcare with some group policies who have been reorganized recently or newly formed. And so it's not in a lot of insurance companies right now. And we're actually telling our patients to check with the insurance company first, make sure that it's being covered, and then advocate for themselves, meaning writing letters, calling the insurance company and saying that this is a new recommendation and that they would like to have that done.
And are you finding that we have now gone through, we started Medicaid transformation several months ago, are you finding that Medicaid, the new Medicaid transformation plans are covering their patients for your services?
Yeah, so we, at our practice, we do have a smaller subset of Medicaid patients than we see at the hospital. So we will sometimes shunt those patients over to the hospital, and for some reason it's covered more there than it is in an ASC. And we do offer other non-invasive testing for them as well. No Cologuard's also covered as well.
Right. Okay. Thank you. Okay. I want to talk about barriers. Okay. And Larry mentioned barriers because of the uninsured and, the most needy of the North Carolinians. And we know that's a barrier. But I'd like for you guys, and I'm going to come back to you, Molly, initially, because you've got it from your perch, both at the state level and nationally. And can you tell our audience, what are the barriers? And then let's get into more of a group discussion about how we might address some of those barriers. So Molly and then Larry, and I want to come back to you, Justin. And Christy, you've overcome a lot of barriers, so we'll maybe give you a pass on this particular question. So Molly?
Well, the number one reason a patient gets screened for colorectal cancer is the provider recommendation. And so even, when we think about barriers and access to colorectal cancer, like that's the first, like the lowest hanging fruit is to make sure a patient is actually being recommended screening and given that given a choice. And, that is a barrier is the providers and care teams, even knowing who needs to be screened. So knowing their own data is something that can be extremely helpful, either knowing based on age who needs to be screened, looking at their data based on race, ethnicity of who needs to be screened, and knowing that can do, just the number one barrier, taken off is just knowing who needs to be screened within your immediate patient population. Education. Knowing that you need to be screened, because even if you are recommended and you don't know the importance of being screened, you might, as a provider, receive pushback and say, okay, well, I'm going to put this off. I'm not going to be screened. And so just the barrier of knowledge of the importance of, what you talked about, Christy, around getting this early, and the outcomes are so much better when we can find it early for any patient population. All of that takes access to care. basic access to primary care. We have so many areas within North Carolina with provider shortages. And that is also, you ask about the Medicaid transformation, Medicaid expansion. In the early expansion states, the highest areas like colorectal cancer screening increased dramatically with low income and African American patients. And we see disparities, significant disparities in those populations. So having just basic access to care creates a space for a patient to even be recommended and become compliant with, with cancer screening. And, transportation, getting to an appointment, is a major reason that an individual who is even recommended does not go and get screened.
Yeah. So,
Frank,
Larry,
I'm sorry,
before,
if you don't mind, Larry, I just wanted to jump in because a lot of the things that Molly just mentioned are exactly the types of barriers and issues that we're working on with our SCORE project. So, this patient identification, our project is trying to build and test a centralized mailed fit. So the fit test that Larry talked about, mailed fit plus patient navigation program for community health centers across the state, trying to test out a non-visit based approach, so more population health screening. And that has required, just as Molly said, like even figuring out who is eligible for screening. So we are working on, with the community health centers, developing a patient identification query through the electronic health record, and then coupling that with mailing out these kits from our central location in Chapel Hill to the 2 community health center populations, trying to figure out ways to get people to mail those back, and then providing patient navigation and supportive systems for the follow-up care that would be required in cases of a FIT positive. So all of those things are added to the visit-based approaches that are happening already. And so usual care is continuing as it is, but we're just sort of testing out what would it look like to do this centralized population-based approach of reaching, just multiple methods of reaching people to increase the screening rates. And so that goes very much in tandem with all of the things that Molly's talking about. On top of that, just working to figure out the transportation issues for people with limited resources or out in the rural areas, and also the access to the endoscopy centers themselves, because they're not always within reach of where people live. And so how do we help solve that problem? These are all the kinds of conversations that are happening within the roundtable and a part of the work that we're doing.
Well, Renee, let me ask you a question, a follow-up. You've been doing this SCORE for how long, this project, and have you seen enough data to give you a trend yet?
So it's been about 3 years.
Oh, okay.
3 years, maybe 3 or 4 years. And we're still mailing out some kits, still collecting data, and working on evaluating the cost and cost effectiveness, so we can figure out how to spread to other community health centers, what we need to know to sustain this. We can see that there are increased screening rates, but we haven't done kind of a formal evaluation at the end. So I would say, a positive trend, but there'll be some more data coming in that we would.
Okay.
Yeah.
Well, that means we need to have a follow-up conversation on Power Hour about this.
Yes.
Yeah. Okay. Larry, I want to come to you, same kind of question, but I also want you to put on your primary care physician hat and talk about, some of the stuff that Molly talked about with the primary care physician, and maybe looking at your data. How do you overcome, if I was your patient and I was resistant, oh, I don't want to do the clean out. I can't tell you how many times I've heard that from people I know. And I'm like, are you kidding me? Blanky, blanky, blank. But anyway, so Larry, let me stop yammering and you answer that question, please, sir.
Yeah, so one of the things that we need to realize about primary care, a lot of our business is episodic care based. So it's driven by an acute complaint. And that's unfortunate because a lot of primary care practices don't have the bandwidth to say, oh, by the way, I know you came in with your low back pain today, but you are overdue for X, Y, and Z, and one of them is colorectal cancer screening. So we need to build systems where the patient can get the care at the same time they're in for an acute complaint. And Renee, offers a model that they're piloting, a visit list prompt to get colorectal cancer screening. And once you have a patient, let's say in a preventive visit, and I would say that maybe 60% of our population goes regularly for preventive visits. I might be wrong on that, but there's a huge part of the population is driven by acute complaints. And so once a person's having the conversation, and then you have to assess the barriers. You got to ask them, can you take a day off work? This does require some preparation. How you do it? I try to sell the colonoscopy because I think it's, for me, it works, and that tends to be a personal peeve of mine. But what I've discovered, there are a lot of people, if you ask about their barriers, they will tell you. And they will tell you if it's a deal breaker. They say, I can't take a day off work. I have nobody to drive me to and from. In which case, if you tell them, well, listen, I have an annual test or every 3-year test that you can do in lieu of that, but I think you need to do it. And these other tests don't require prep, but if you do it on the schedule, it probably is just as good as a colonoscopy. So I think those are the kind of conversations, building the systems and then also assessing the barriers at a primary care level.
Well, there's a common theme that everyone has talked about, which really is the social determinants of health. It's about transportation, it's about jobs, it's about access, and which of course is, we know that that's happening. Justin, I want to come back to you. I've got a question in here about African Americans are 40% more likely to die from colorectal cancer. Okay. And I put in the chat, or I think we did, an article from the New York Times about this. I'm sure there's a lot out there in the literature. Renee's the scientist. She can probably tell you that. Anyway, talk a little bit about what makes that percentage so bad. What are those underlying things in those African American communities that make that number jump up like that?
Yeah, so obviously we know that they're at higher risk for colorectal cancer, and it's also mostly more in the male population than it is in the female population. There isn't a study that I've seen that can pinpoint it to one individual reason, but I will say a lot of their screening and diagnoses happen later than the recommended screening age. And I think that's because they present later for screening. And that's one of the big disparities probably that needs more research and figuring out how to actually drive these people in to get screened sooner. And so what we try to do is obviously, if you have additional risk factors, we stratify them, at least most likely on paper, but at least in our heads, knowing that we're going to find some precancerous lesion on an index screening. And that's one of the more important things is we looking for these, especially flat lesions that are seen in the right colon that are accounting for about 30% of colon cancers now. Those are the sessile serrated lesions and sometimes traditional adenomas. And so we're looking at those, and obviously we're using quality benchmarks to try to ensure that everybody gets an adequate colonoscopy where we're spending enough time looking, 6 minutes for withdrawal and double intubation to the right side. But the main thing is bringing those people in and prepping them accordingly, because we know that also whenever they come in for that index colonoscopy, if they have an inadequate prep or they're delayed to another time, they're more likely not going to show up for that repeat colonoscopy. And so sometimes colonoscopy is not the right test for everybody. It is the Cadillac and gold standard because it has 100% sensitivity in the right setting. And it also can be therapeutic where you remove these precancerous lesions. But also know that FIT testing once annually plus or minus colonoscopy every 10 years is equivalent or superior to that, and also more cost effective than some of these methylation tests, including Cologuard training. So
okay.
I don't have the answer yet, but I think a lot of it has to do with some things we're seeing with COVID vaccine, where it's hard to actually like stimulate different populations to get screened earlier.
Right, right. Thank you. I want to come back to this standard that's been moved back. We talked a little bit about it from 50 to 45. What are the reasons for that? I know that the American diet is not, in general, very good. And Christy shared her story that she eats plant-based diet, it sounds like, a lot. So, Molly, do you guys have statistics or reasons for that moving back? Is it diet related? What are the what drove that number down?
So what drove the number down is just looking at the data of when individuals are being diagnosed and what is that threshold for what makes somebody average risk. And so it is like you said, where our bodies are because of diet and all the reasons is different than several generations ago, but it's really driven by looking at that data on a regular basis and saying we need to move this. We need to move this because we're finding that the average risk individual is being diagnosed early. And one of the things that was happening is while we had 50, once we started looking at the data, individuals weren't being screened until like 55 because they were coming in and getting that first recommendation and then they weren't showing up. And so that's the other thing in looking at your data. Pull your data by race, ethnicity, pull it to look at your patients and what you're seeing at any point in the continuum. Screening, stage at time of diagnosis, outcomes of treatment. Look at that, but then also look at it with age, so you can make sure you are getting that. So really, it comes down to, because the other thing in this is about risk. And Christy, you said it so beautifully. And your doctor actually had asked those questions and had those answers in front of him. And there are different pathways for that, but it's also listening, because we have more early onset. We have some major hotspots in North Carolina with early onset colorectal cancer. And it is really about listening and asking the questions to see if there's any kind of symptom. And then not, like Justin said, if you hear that around, not dismissing it or attributing it to a fissure or hemorrhoid, saying we need to listen to this.
Yeah, that's exactly right. Now I want to move to the opposite end of the spectrum and talk about, as we get older, at what point does the American Cancer Society, Colorectal Roundtable, Justin, et cetera, say, should there be a time that we should not take that risk? Is it 75? Is it 80? And I know it depends, but in general, what's that recommendation from the American Cancer Society?
So the recommendation is based on an individual patient. And so starting to assess that at 75, if you have a patient who has a comorbidity where that is a life, their likelihood of surviving past 10 years is attributed to something else, that is something to consider. However, the recommendation really is based on at 75, starting to really assess that, because you're going to have individuals who, Chrissy, your grandmother lived into her, her 90s. It's not stopping at 75, for her, but really that being the trigger, just really start assessing, is this the right screening? Because it might be that you need to change screening modality, where the colonoscopy, there's risk and benefits for everything that outweighs because of other things that are happening with an aging patient, that you need to make that decision.
Yeah. Larry, is the Colorectal Cancer Roundtable in agreement with that?
Yeah, we put out recommendations that are mostly in line with the U.S. Preventive Task Force recommendations. And starting at age 75, we see the sunsetting of the need for screening. If you have somebody that is physiologically very young and their longevity has a high probability of exceeding 7 to 10 years, that's a context where you would recommend screening. So it is in individual patients. conversation.
Okay.
I would add too, anecdotally, I've seen patients, obviously we're offering screening up to age 85 in the right patient where it seems like it'd be beneficial. Yesterday, for instance, I had a guy who's 78 years old and decided it's time for his first colonoscopy ever. And I removed a 3.5 centimeter pedunculated polyp from the distal sigmoid. And so that's a lesion that definitely was going to turn into a cancer probably in his lifetime and would have severely changed his lifestyle and increased morbidity, for instance.
Wow, that's a great story. Justin, do you see any new technologies, any new screening things coming up, any protocols that we ought to be aware of in the near-term future?
Not really. I mean, I think we have to use the tools that we have right now, and they're trying to figure out how to institute some other smart technology. One of the other ones is a liquid biopsy where you have methylation markers in serum. And right now we're not recommending Septin-9 unless the patient adamantly requests that test. But I think that's probably where the future is going. And we're trying to, again, offer this to at least 80% of the population so that we can capture most of these patients and then figure out who needs a therapeutic or has a high likelihood for positive findings on a diagnostic test.
Yeah, it's very interesting.
So Franklin, we have something that we're doing that's
Okay.
novel in this
Please.
area, and that's of course exploring ways to increase access to screening. And one of those ways is through pharmacies. So
Yeah.
we have a project that we're working with called FarmFit. And, we started down this path because of course we see geographic variation with access to healthcare, which we've already talked about. Folks in rural areas often living far from primary care offices, facing transportation barriers. And, so they have less access to their doctor for regular screening, but pharmacies, of course, are far more abundant. And often a person has more ready access to a pharmacy than their doctor's office. So we are right now working on a demonstration project involving testing the delivery of fit kits through pharmacies. We've been talking with pharmacists, primary care providers, patients as part of the research to find out what they think of the idea and what will it take to make it work, what might get in the way. We've learned that it's very appealing to all three of these groups with some caveats. And so our next step right now is to pilot an intervention and see how CRC screening within pharmacies could work. So we're really excited about that project. That's something new in screening that we're doing.
That's very cool. That's very cool. Thank you, Renee. Okay, guys, we're almost at the top of the hour. I have one question that I'm going to give to everybody. And it's just your chance to say to our audience, to get your, last chance to say you need to be aware of this and give us your 2 cents. Christy, I'm going to come to you first.
Okay.
What advice do you have for our audience?
To not discount their age and, ruling them out as a cancer patient. A simple, hey, have you ever experienced any bleeding or consistent cramping? No? Okay, great. If you do, I want you to follow up with me. And then you continue on with the appointment.
Super. Thank you. Larry, how about you, sir?
We need local advocacy and people to deliver the message. We need to have more trusted messengers. We can rely on primary care providers, and for various reasons we covered, it's a great start. It's probably the most influential start, but then we also have to have local advocates to just get the message out, so patients will ask to get screened.
Super. Thank you. Molly, how about you?
Just recommend it and talk with your entire practice. Be a good neighbor within your medical neighborhood to really see, because there are resources and there are things that are happening in your practice, in your medical neighborhood, and some conversation can go a long way with getting patients in a place where they're not falling into a crack.
Super. Thank you. Renee, what advice do you have for folks?
I guess I would just echo that's, this focus on screening and join in the vision of a statewide screening program and come to the roundtable, talk to, as Molly mentioned, and Larry talked to others about how to increase screening and reducing barriers to screening.
Super. And finally, Dr. Miller. Advice?
Yeah, I would say that I think overall, we're doing a good job, screening patients. The number of cancer deaths are dropping. And I think we're going to hit that benchmark where we're screening the majority of patients, realizing that not every test is perfect, including colonoscopy. And the best one is obviously the one that fits your patient. I do like how we have these additional efforts to screen more patients and get them actually to the medical provider. I think that's definitely going to help. And those community outreach programs are definitely something we need more of.
Right. And the last suggestion from Christy was a colonoscopy is a lot better than surgery, chemo, or radiation. And I think that's a brilliant way to end our discussion today. I want to thank all of our guests for this robust discussion. Thank you, Dr. Miller, for joining us a little bit late, but thank you for getting that colonoscopy in there today. I'm going to turn it back over to Tina. Thanks, everybody.
Thank you so much, everybody. And this wraps up our Power Hour for today. Thank you to everybody who was with us in the studio today. And Power Hour is going to take a little bit of a break. We're going to come back in January, so please stay tuned and we will keep you informed of what the topics will be. We will actually come back and revisit this topic again. We wholeheartedly decided on that prior to this session that this is much needed and we need to come back. So chances are you will see our speakers again sometime soon. Thank you so much for today. Thank you to everybody who was listening. Thank you to those of you who will download the recording. Again, the recording will be available within about a week or so. Without any further ado, have a wonderful weekend, and thank you so much for the work that's being done and for being here today with us.
Thanks, everybody.
Thank you.
Thank you.